So this is the case of chronic contracted cholecystitis. You can see it is a very much small contracted gallbladder, and the MRI of this patient shows stone is in the cystic duct on the CBD junction. So it is very close to CBD. Long cystic duct is going close to CBD, and then the stone is obstructing there. And I gave ICG in the previous day, and you can see the liver is only the liver is getting highlighted, and there is no blood vessel is highlighted when you are making it in a IR mode. So I just making the port 5 mm port in the right subcostal, and then right lateral port for retraction of the gallbladder. So all the port is being placed towards the gallbladder, you can see now, so that the pain, postoperative pain on the port side will not be there. So it's very much contracted. You can see that it's like a fissure, fissure in the split in the liver, and the gallbladder lies within that. Most of the contracted gallbladders is like this, long-standing thing, because of the obstruction of, usually if it is a cystic duct obstruction, gallbladder got distended, and if it is a chronically treated case, and it become a contracted. Each time it is treated with antibiotic, then that area become fibrosis, so it's become a contracted gallbladder. So that is a omental adhesions. So I'm using ultrasession forceps for separating the omental adhesions. I hold the fundus of the gallbladder. See, I'm seeing the gallbladder wall now. So the very thick omentum. So I'm releasing all the omentum, and you can see by appearance itself, it is a chronic case, acutely treated a long time, and it's become a contracted and chronic. So it is a little bit gallbladder is there. It's not much contracted gallbladder. It is a chronic cholecystitis. So I'm coming down. So once you see the wall of the gallbladder, you can go close to the wall, release all the omental adhesions, anterior and medial and lateral, so all the area, and you can see the duodenum down. I come up to the duodenal level. So that is the rubeus sulcus. Once you see the sulcus, the infundibulum will be there, infundibulocystic junction, and you can see the right hepatic duct, right duct, and the rubeus sulcus. So at that level, I have to stop. Otherwise, if you go down, I may injure the CBD. So I'm started doing laterally. It is on like anterior callus dissection. I have done it, and always Maryland with the monopolar cautery is ideal. And you can see the chronicity, you can able to feel it when I started dissecting the infundibulum. So a lot of fluid, that means that is the fluid in the wall of the. So now you can see there is no plane between the infundibulum and the right hepatic duct. Usually, I used to tell in my previous videos, always remember that infundibulum is lying on the right duct. So once you open the peritoneum, posterior peritoneum, and then lift the infundibulum, create the space. So now I made IR mode, and you can see the infundibulum, CBD is seen, common bile duct is seen well, and you can see this, that is the cystic duct. So according to imaging, MRCP, cystic duct is going parallel to the CBD, and then it's long cystic duct, thick cystic duct, and then it's open into the CBD, very low down, low insertion of cystic duct. So now you can see the CBD very clearly. So that is the infundibulocystic junction, and you can able to see the node there. Just below the node, artery will be there. So this case, it is really IR mode, that is ICG mode is helping me to do this case. And that you will appreciate when you are watching the video. So I thought now I'm just taking the node and I'm just dissecting the artery. So I'm dissecting the cystic artery. So basically that is the infundibulocystic junction, and here I cannot divide the cystic duct on the infundibulocystic junction, that is a safety zone, but here this case the stone is on the cystic duct CBD junction, and the cystic duct is very long cystic duct and it has a low insertion to the CBD, just no very suprapancreatic level, no, it is going there. So I have to go down, and so I just dissecting there. That is that area is like a wide cystic duct. It's look like a infundibulocystic junction. It's not like a contracted area, so it is very much wide. You can see the ICG mode is helping me very lot. Since ICG is given on the previous day, it is not staying in the it is washed out from the venous and artery circulation. Now you can see it's only in the biliary. Now it is there. So it is a chronic case, treated case. So I am not able to. I thought no, I have to divide this infundibulocystic duct junction. Then I can able to trace the cystic duct till the lower end of CBD. So that is my plan. So otherwise it is very difficult. No, it is very hard. You can see when I started division of the cystic duct, it is a long cystic duct. You can see the thickness. So I thought it stone is here only, that much thick is there. Initially I thought this is here is the stone. When I remove the stone and then I suture the duct, so that is what my plan, because it is by touching with the Maryland dissector, it's very hard. You can see the wall thickness, how much thickness wall. So then finally I realized that okay, the MRI is correct, report is correct, because it is only the thick wall, not the stone. So always do MRI in a difficult case. If you suspected a multiple attack or acute or gangrene, instead of instead of ultrasound, you can go for a MRI. So it will give more findings, rather than the ultrasound. You can see since it is a Rouvier sulcus is very low down, I could able to see. I am just dividing this just above the sulcus level so that the right duct will not get injured. So now it is a normal mode, and again you can see I changed to IR mode, and I have to go down and I have to take down the stone. Now the entire duct is very thick, hard and thick, so it is a low insertion of cystic duct. So that is the duodenum. You can see the bile in the duodenum. The color is seen in the green color, in fluorescent green. So that is the artery, the artery to the cystic duodenum. So I am retracting the duodenum down, mobilize the duodenum, and retracting down, and then I am going to the lower CBD. I could able to visualize. Then I can go for the removal of the stone. So how much medial I have to come? You can see the ICG is helping me, so I cannot come this side. So I have to go on the lateral side. No, otherwise I will injure the CBD. So I feel real use of ICG in this case, and that ICG IR mode is helping me a lot. Each and every dissection or division of any structure I am seeing in IR mode. So that will be very much helpful. See how much it is close. You can able to see very densely adherent. If I try to separate the cystic duct from the CBD, definitely I will injure the CBD. So this case it is not, stenting is not done preoperatively because there is no CBD, no obstruction. So just with the IR mode help, I started doing the procedure. So that is the CBD, and what I am holding is the cystic duct. There is no plane between the CBD. So that area I feel very hard. With the suction nozzle I am just touching, that stone might be there. You can see how much down it is, more than 5 centimeter down from the infundibulocystic junction I divided. I am seeing the right hepatic duct on and off. So our aim is we have to take the gallbladder, entire gallbladder, remove the stone without injuring any structure. So that is our aim. So that's why check all the areas clearly and then go for a division. So that is the cystic artery clipped one I divided with the ultracision. Now I am dividing the anterior wall of cystic duct here. You can see how much thick it is, and it is very hard. You can able to appreciate when I do this harmonic division. You can see. So now I enter the lumen of the cystic duct. Can you see how much thick duct wall? Normally the wall is cystic duct is 5 mm thickness. Here each side wall will be 5 mm thickness. See that mucus kind of secretion is coming. It is not a bile. So I find out the opening. So I don't want to take the post wall of cystic duct that will be adherent to the right hepatic duct. So I cannot remove the post wall of cystic duct here. Then I injure the right hepatic duct. So such a difficult case, difficult situation. You can see I open the cystic duct. So again I am saying the CBD. So it is really helpful. ICG is really helpful, and the camera surgeon, my surgical gastro postgraduate, and he is telling each and every time, sir, it is really helpful, sir, ICG is helpful. So he told me, sir, without ICG we cannot do this case like. So it is helping. It's definitely it is helping. So again, I am mobilizing the duodenum further down. Usually in a colorectal cyst excision or sometimes CBD exploration, we used to mobilize this duodenum like this. So it's mobilized down. Here that hardness I could able to see down till down. Another 2 centimeter I have to open. So I'm doing entire surgery with the ICG mode only, overlay mode. So again I'm mobilizing the duodenum down. So with the help of ICG, boldly I am just opening the medial side of the cystic duct. That is the cystic duct and the CBD junction I am opening. So that is the level it got inserting into the CBD. So because of the ICG help I am doing this. So now you can see the stone. It's an impending stone. It will not come out because it is a tissue overgrowth on the stone, it looks like. So I am trying to remove the stone. That is the stone in the cystic duct GBD junction. So it got broken. So even if it is a broken, it's no problem. You can able to remove it fully. Little difficult access case. Very low insertion of the cystic duct to the CBD. I cannot open medially because CBD is there. So with this opening only, I am trying to remove the. So slightly I am opening the inner wall. So you can see here. So now it will give a little bit better access of the stone. So I am removing a bit of all the stones bit with the 10 mm stone holding forceps. So now it is coming out slowly. If it is a CBD stone, by milking out it will come, but this is at the junction, no, the curvature area of the cystic duct. So we have to be, it will not come by milking it out or pushing down. Now you can see the bile is coming out. So that means the stone is, no, where I am removing the stone. If you see the clear bile is coming out, then means the stone, all the stone is being removed. The entire stone is removed. See how much, by ICG is giving helpful, and you can see the bile, how much fluorescent green, the bile, you can see how much it is coming. So the bile flow, clear flow indicates that clearance of the stone. So it is coming out very nicely. So I am taking out all this debris material. So this extra port will be helpful, and again you can see a lot of bile is coming out. You can see the bile in normal mode also, but this is very clear, very much clear. Even at one drop of bile, you can able to identify with this fluorescent green. So I have to decide whether it is completely removal or not. So I am taking this one. I have to give wash, nice wash. I am not able to feel the hardness. Previously, with the suction nozzle, I could able to feel the hardness is there, but now there is no hardness. So this is a normal mode, and I am taking the suction catheter. Might be 10 size or 12 size. I am introducing inside, and then I am giving wash. Maybe any small debris is there, small stone bit, it will come out. It will go very easily, and they are injecting saline from outside. So it is very free flow. It is going easily. Flow is also pushing a saline also easier, and I can able to move this instrument. So move this catheter well. That means it is going slow into the CBD. See now the small stone is coming out. So almost I am in the cystic duct CBD junction. So all this tube is easily enter into the CBD. Actually, I am giving wash to the lower CBD basically. So now I have to close this cystic duct CBD junction opening. So now again IR mode. So I am taking this is the PDS Maxon now Maxon PDS 20 PDS. So I am started suturing the cystic duct at the level of CBD, that is a cystic duct CBD junction, and you can see how much I divided from the division. It's almost 5 to 6 centimeter down. I come down and then I take down the stone. So it is a I'm taking you can see the turning out of this cystic duct. It is turned medially. So that area stone was there. I remove and then I started suturing it. So very ICG was very much helpful, and you can see the laid open cystic duct is more than 5 centimeter. One of the very difficult case. So it was managed well with the help of ICG. So now I put IR mode. My PG is so happy, and he is making this mode. With the one button in the camera head, they can make this mode. So frequently he is doing this ICG mode and then checking it out. So now what I have to do. I am going to give thorough wash, and then I am going to keep a fresh gauze piece, because this gauze piece may be bile stained. So fresh gauze piece. So after the removal of the gallbladder, I am going to check the gauze piece whether any bile is coming out or not. And this case, I don't know whether CBD is stented or not. And if it is required, you can do stenting post-operatively if it is a bile leak is there. But there is no bile leak post-operatively for this case. This was done recently. I could remember there is no bile leak. Even see the suturing side also there is not after suturing there is no green color there. You can see the gauze piece no green color, that means the bile stained gauze piece. So I have to remove the gauze piece, I have to keep a fresh gauze piece. See, fresh gauze piece, I am keeping it that area. Then I started mobilizing the started exercising the gallbladder. Again you can see the CBD is very clear, very well demonstrated here. So when you are having ICG, use this type of cases. Always when you are doing a gallbladder, don't give ICG on the day of surgery. You have to give previous day night, so that it will be only the liver and bile will be stained, and all the vessels will be ICG will be washed out. So 1 hour before, 3 hours before, it's not good. Before minimum 6 hours. So the previous day night is ideal one. And some of the cases adhesolysis also I give the previous day night. So I could see when you are doing adhesolysis, I could see the bowel is green color, and then adhesions will be the pink color. So I could see the line of demarcation is very well seen. So that will be helpful for adhesolysis. So always gallbladder means give this ICG on the 1 day prior. There is a previous day night. So the excised gallbladder is placed into the endo bag, and it is a thick wall. So I am trimming it, otherwise it will not come through the 10 mm port. Cut it into pieces, 2-3 pieces, and then take it out into the 10 mm without enlarging the port. So it was without enlarging. I take out into pieces with the bag, plastic bag protection, so the port site is not getting infected. So now I am just checking the gauze piece, sucking it out. I made into the IR mode. Can you see the intensity of IR mode is little less compared with previous. So now you can see there is nothing is there. There is no bile leak. So it is a completely closed. That means it is after half an hour, 20 minutes or half an hour, there is no bile leak. The mucosa of the cystic duct to be cauterized, and this is the excess infundibulum, sorry, cystic duct is excised, and you can able to see the right duct very well, and I am just coagulating the mucosa of the cystic duct with the bipolar forceps. So almost 7 centimeter from the infundibulocystic junction, and 7 to 8 centimeter distance it is coming down, and then it is inserting into the CBD. So with the ICG help, I could able to trace out the cystic duct, and then I just did the surgery, and I keep a drain, little large drain for always suturing the CBD or cystic duct and infundibulum. Keep a large drain and keep it for 4-5 days. If it is a bile leak post-operative, do ERCP. Otherwise, after a week, you can remove this drain. I send the patient with the drain, with the cut the drain. I place the bag, colostomy bag, and then I send the patient to home. And then after a week or 10 days, I do ultrasound, LFT. Everything is fine. Then I'll remove the drain. And if we see the bile leak in the first day or second day, I do a ERCP, and then I send home the patient with the drain. Thank you so much for watching the video.